healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome back to another episode of Coffee with Coker. My name is Mark Reiboldt. I'm the host of the podcast. Today we're talking about rural medicine, rural healthcare, and some of the challenges that rural healthcare organizations face and some of the solutions that are being brought to the market that we think here at Coker are very interesting. So joining us today, we have Chris Pusey. And Chris, I appreciate you being willing to join us. And we also have Richard Romero, who's one of Coker's senior vice presidents. But what we want to do today is talk to Chris about some of the things that his organization does. And his organization is called Partners in Rural Medicine. And of course, Coker does a lot of work in rural healthcare services space. And obviously that's something that is a major part of what our audience and our client base deals with as far as some of the challenges in that particular segment of the market. So I think it's going to be an interesting discussion. I'm looking forward to it. Before we dive into the discussion, real quick, I wanted to cover, as I always do, a couple housekeeping items. Just a reminder for everyone, you can listen to not only this podcast episode, but all of our episodes of Coffee with Coker at coffeewithcoker.com. So if there's anything here that is of interest, I'm sure there will be other episodes and other topics that would be of interest to you as well. So feel free to check that out, along with the rest of Coker's content and our digital content library covering all kinds of healthcare services, finance, and business topics for healthcare organizations. So I say all that and to also say if there's any questions, feel free to reach out to us, and we would love to get your questions or recommendations for future topics and episodes. But with that, I really want to jump into the discussion here. Chris, hey, thanks for joining us today.
Yeah, Mark and Richard, appreciate you guys inviting me, and excited for the conversation. We love the opportunity to talk about what we're doing, and super passionate about rural healthcare.
Absolutely, as are we. That's I think that's something we definitely share. So, Chris, before we dive in here, maybe just for the benefit of our audience, tell us a little bit about yourself, your background, but also what does Rural Partners in Medicine do? Tell us a little bit more about that, and like how long you guys have been around, and who you work with, those types of things.
Yeah, absolutely. So I started my career out in the physical therapy space, really with a background in finance and accounting. And I went to work for a company that was private equity backed and kind of a pretty fast growing platform. It's now one of the largest platforms in the country. So I got a lot of education on kind of operationalizing a organization and learning how to scale organizations up. From there, I actually went to the private equity side, and I spent 8 years investing in healthcare services companies and kind of traditional LBO markets. And then subsequent to that, I've been running several organizations in healthcare and outside of healthcare. And then most recently with Rural Partners in Medicine, which is about 3 years now with them. And grew up in Colorado, was a competitive mogul skier for a number of years. And kind of that competitive streak has kind of fueled a lot of my both personality and just drive to kind of grow organizations and be successful. So that's a little bit about me. As far as Rural Partners in Medicine, the organization is about 10 years old. It was founded by an orthopedic surgeon, Dr. Brian Shear. Interesting kind of evolution of the company. Dr. Shear was living in a little bit larger rural community, running a private practice orthopedic group, and kind of going about the market in ways that you kind of see out there still to this day, where a group will come in and do outreach into smaller communities, smaller rural hospitals, and provide clinics there with the aim of taking back the surgery volume back to kind of home base. So he was in a model that you still see today. A lot of the large groups out in the market continue to do this. So the big hospital systems will send groups out. And so he got to know kind of the administrators and the hospital staff, was working with the nursing staff, was looking around these hospitals going, hey, you've got a couple of operating rooms that are underutilized. There's not a big line for time in the OR, or block time in the OR. You have the full kind of capital invested here and the human capital as well. There's really no reason I can't operate here. Why am I not operating here? And started to sort of ask the questions about what made the most sense. And I think what he kind of concluded ultimately was that the big opportunity for the hospital was the technical fee side of things. And if he could do the surgeries there, he wasn't, indifferent, at least financially, to doing it. It might be a little bit more difficult to kind of build the practice up initially, but that there was a real opportunity to kind of drive some financial opportunities for the hospital. And I think, honestly, he's such a mission-driven guy that when he was looking at it, he really understood, too, that when you look at these rural communities, the hospital is oftentimes, the 1, 2, or 3 largest employer in town, and they're very good jobs with educated, employees and those types of things. So there was this kind of bigger impact to rural communities beyond just the 4 walls of the hospital that could be done by just driving financial performance in the hospital and doing surgery local. So that's really how it got started. He ultimately moved to Colorado, up in the mountains, in a ski resort town, and then had to get to work from there. So that's kind of where he invested in the first plane and hired a professional pilot and kind of got to work in his practices out in these markets. And then, it kind of just snowballed from there as word of mouth got out as to what he was doing. He was doing like 3 or 4 programs at that point. One of the key components to our model is that you have this recurring schedule, like a permanent schedule. So he might be in one community every other Tuesday, so just as little as 2 days a month, where he's running, part clinic, part OR time. And then the next community might be a little bit bigger, or maybe the program's grown a little bit faster, and he might be there, say, every Monday. And then a third program, he might be there, every other Thursday. So he starts to have this kind of permanent recurring schedule. The community starts to know that he's there on those days. The hospital, he really just starts to integrate with the hospital as kind of part of the hospital staff. So word of mouth starts to get out, and then he starts getting calls, and then pretty soon he's busier than one surgeon can handle. And it turns out that where he was living in a ski resort town in Colorado was sort of a perfect breeding ground for the expansion of RPM. And the reason for that was, like many urban markets, ski resort towns, physicians kind of choose to live where they want to live, despite the fact that they might be highly competitive, or that the market demand on the patient side might be smaller than if they were to go to, like, say, a rural hospital or something. So they make that choice. So when he got to Colorado, he was like the 10th board certified orthopedist in town. And really, if you look at the volume of that town, there was probably enough work for one full-time equivalent physician there. So you've got this massive oversupply of physicians, which made it really attractive, because he basically went to many of the doctors in town and said, hey, I know that you guys love living here and want to be here, but that you're all kind of chasing the same patient base. So let's say some of you are 60 or 70% busy on your time. Why don't you give me 2 or 4 days or 6 days, depending on how busy you are, a month, and I'll take you to a rural program, and you can help build, orthopedics in some of these rural communities. So there was an obvious draw from the physician side on a couple different angles, one of which being like their own kind of personal efficiency and time, and obviously economics, like that piece is important. But I think there was also a huge component of getting back to why, you go to med school to begin with, which was really about patient care, and staying focused on that patient care. One of the things that works for the physicians on our side is that, they basically get to get on a plane, come work in a rural town, and they get rid of a lot of the kind of headaches of private practice, whether it be, dealing with billing and collections and insurance companies, or having the employee base that have direct report to you. Kind of all those struggles kind of go away, and they just show up at these rural hospitals, and they get to integrate right away and just focus on patient care, and then come home at the end of the day and leave some of the business stuff behind, many physicians aren't, while they're really smart folks, they don't get classical training on running business, right? I mean, it's all medical based in their training. So there's components of it that are just not something that they've trained to do. So I think that it reinvigorates a lot of them as they start to get involved with us. But those kind of things were what started off the company and made kind of this market work. And then, fast forward, we've gone from just general orthopedics to we provide every kind of subspecialization of orthopedics. So we do hand surgery, foot and ankle, total joint, sports medicine. And then we've expanded into spine and pain management. So we do some spine surgery in some of these rural markets. And then from there, we went into general surgery, urology, ENT, some GYN. We've done some emergency medicine support stuff as well for some of the ED programs out there. So that's kind of what we do on the surgical side. RPM from there has also done some interesting things to continue to enhance our service offering in specialty medicine to rural hospitals by partnering with some other companies on the physical therapy side of things, on the ophthalmology side, and then we also have an implant distributorship on the orthopedic side. So we're kind of holistically trying to identify really good opportunities for rural hospitals to generate new sources of income or maximize revenue with existing lines. So that's really our big kind of mission and aim at this point. And so we brought some companies together to solve those solutions.
Yeah, that's a lot of interesting stuff there that you covered. And I want to circle back around to a couple of these things. But, it's interesting because Coker and a lot of our clients over the years, I mean, we work with a lot of what you would call rural health facilities, whether it's everything from a acute care in a smaller market that you probably still consider rural, all the way down to the critical access hospital in a definitively small market, and those types of resources and opportunities for income and revenue expansion and really just coverage opportunities there for certain services it's been a hard nut to crack for many organizations. So I really like the idea of bringing that back. As we know, it's easy to get kind of caught up with the scale and scope of services that are typically concentrated in your larger metropolitan areas, urban healthcare facilities, larger hospitals and health systems, et cetera. So the wide range of services that those types of facilities can provide. But the real largest volume of true healthcare, medical care happens not in that type of setting, meaning it's all types of settings from the rural all the way to the urban. And so, again, this has been something that's hard for these types of entities to really figure out or keep. It's a hard balance. So talk about, though, and again, I want to circle back to a couple of different things you alluded to or referenced, but let's talk about the rural market for a second. First of all, if you don't mind, what do you guys view as quote unquote rural healthcare? And two, talk about some of the challenges there that those types of providers and facilities are facing.
Yeah. We oftentimes equate rural with critical access hospitals.
Sure.
Which those towns, just to give some perspective, are usually between 2,500 and maybe 10,000 people in town or in the community. So that's a little bit what we define. The reality, though, is that our service offering is starting to get recognized at another level above that, where you're still in somewhat of an isolated community, but maybe not a critical access hospital. So it may be not-for-profit hospital, but kind of next step up in size. So somewhere between 26 and I would say 75 to 100 beds maybe, but outside of kind of city limits. So that is becoming more of a recognized market for us. But I would say really we originally designed the service around the critical access hospitals and supporting.
Gotcha. Yeah. Which again is a key area of need. I think those types of communities and the facilities that serve them, it's tough to crack that nut. Talk about maybe the some of the challenges as it relates to the patient base that are typically seen in those types of markets and by critical access hospitals, the patient characteristics.
Yeah, so I would say as you look at the patients from our perspective and most of the surgery that we do, they look very similar, honestly, to urban. What I would say is that there's a big cultural difference. So, I think most patients in these communities would much prefer to stay local. And when you have to drive 100 miles or more to get specialty services, I think what happens is you get a lot of deferred care, or you get the avoidance of care altogether, which can lead to kind of more complex cases down the road. So there are some kind of potential issues for that. And so we do see that from kind of the patient base. I think in some of the other subspecialties, that stuff that we don't do, I think that there's probably an even bigger difference in the patient population there, and the deferral of care and what that could mean for kind of the healthcare system more broadly. But with regards to kind of orthopedics and elective style surgeries in some of the other subspecialties, we don't see as much of an impact in the patients we're serving, other than just that traveling and maybe deferral of care.
Yeah. To me, it seems like there's two overarching, I don't want to oversimplify this, but two overarching barriers for these types of facilities to do what you're talking about. One is the financial challenge, right? The making it feasible financially. The other, I feel like, has that we get probably the most pushback on, or I don't know, pushback may not be the right word, but some of the challenges that come with it are the quality aspect. Meaning, you have these facilities out there saying, "Listen, man, we can't manage this type program or these types of in-depth procedures. We don't have the staff resources. We don't have the physical infrastructure, et cetera." And I don't know how long ago, but let's say 10 years, maybe less than that. 10 years ago, if someone was in a rural community 150 miles outside of Denver, let's say, and they needed a spinal fusion or some sort of neurosurgery, it would just be automatically assumed, you're driving to Denver for that and everything related to it. Now I feel like that's not necessarily the case for certain things. Would you agree? And where do you guys, how do you feel about that? Where do y'all come in with that type of scenario?
Yeah, well, certainly, we feel like we're part of the solution to keeping folks at home. So, and I think that over time, I think some surgeon and surgeon groups have moved to what I would call kind of that second tier rural community, and then done outreach and done some surgery in some of these locations. So we are starting to see that. And then obviously the patient acceptance of staying home and all of that, and just kind of building these programs in these facilities, has developed over time. But I want to hit a little bit on the first part of your question, which is, why does this work? Why is it difficult for hospitals? I mean, one of the things that's really difficult for these communities is just, it's somewhat financial, but it's also just that making it attractive to surgeons is difficult, because oftentimes there's just not enough volume. So while there's definitely cases to be done in all of these critical access communities, there's just not enough to have a full-time equivalent. So one of the things that's really difficult from a hospital perspective is, like, how am I going to get a partial surgeon out here, and how do I make that attractive for them? So, I think our model really addresses that concern. When we see hospitals recruit full-time surgeons, it often does have, and I don't like making kind of broad sweeping statements, because there are absolutely great surgeons in some of these rural communities that are unaffiliated to RPM. But sure. I think there's a draw of a certain type of surgeon that would go take a full-time position with pretty significant guaranteed pay, but really maybe only 20% of the work that you would have to do in an urban market. So I think that's kind of the imbalance that happens, and it's just a hard problem to solve. And so what you get are, you do get some good groups in kind of second-tier rural hospitals that will do some outreach. You have the traditional outreach model that I described that Dr. Scheer was doing previously. So you're seeing people get seen, at least from a community standpoint, on the clinic side. And at least you have a doctor and then you go travel to get your surgery. But we just think that, we think that the real opportunity is to keep the surgeries local. And honestly, there's some studies out there that would support that outcomes are better from that standpoint, that anytime you infuse travel in a patient's experience, the outcomes are worse. Obviously, from just a mental health perspective, having to go through a major life event like a surgery and have to be displaced from your caregivers at home and going into a market that you don't know and having to stay at hotels, all that kind of stuff has just negative impacts. So we're just really think that this model is one of the few we've even seen out there that kind of solves a lot of those issues for critical access hospitals.
Yeah, I could totally see that. I mean, it's a huge deal, and I think sometimes it's probably we don't fully realize the negative impact that type of experience can have. Like you said, I mean, having to go and stay at a hotel or have family members stay at a hotel or not having folks come and visit and support you, whatever. I mean, just basic things. But then you get into, you kind of go, it gets bigger and bigger from there, I would think, as far as the challenges and even just the logistics of it, and then the cost associated with that. Right. So I think that's interesting.
Chris, this is Richard. I have a question for you. Obviously, there's the financial aspects and the technical fees associated with the actual surgeries. But we see a trend, obviously, in rural markets with a number of rural facilities closing because they do not have the financial ability to essentially stay alive. What are some of the perhaps downstream impacts at the hospital beyond just the technical fee from the surgeries that they're providing? What are some of the other impacts that you're seeing that your program is having at some of these facilities?
No, it's a really good question, and it's part of that. I kind of wrap it all into the financial impact discussion, but it's a really good clarification or distinction, because obviously there's the surgery that drives revenue on its own, but there's a ton of downstream ancillary revenue that's generated from doing surgery, whether it be orthopedics or otherwise, that often leverage a lot of pre-existing infrastructure for the hospital. So it's not a big investment for them to go out and kind of build these services because they have them. But yeah, you're going to start using the lab and imaging, therapy, rehab gets a huge kind of bump, usually from orthopedic surgery. So yeah, there's a significant amount of downstream impact as well that gets leveraged on a pre-existing fixed cost infrastructure. So there's a big impact from that.
How do you guys kind of get involved in that? Describe kind of the ideal scenario and the partnership structure that you guys have with a facility, and what does it look like, soup to nuts, if you will?
Yeah, so when we first get introduced to hospitals, we kind of come in and have some, discussions about where the perceived community gaps are in specialty medicine, and then we basically customize the solution to them, both on schedules but types of physicians we might bring in, whether or not we do general orthopedics or we do subspecialization of orthopedics. So there's a number of things that we assess as we get going. And then we obviously go out and recruit physicians based on the demand, with usually the opportunity to grow. Most of our programs, we start really small, and we start them small intentionally, largely because we've just seen that the success rate goes way up if we start small. So, for example, we might bring in orthopedics only twice a month to start. We're going to do half day clinic, half day in the OR. We're going to build that volume up until it's really sustainable and efficient. As we discussed earlier, one of the big draws for the physicians is that they can come have a super efficient day. Well, that's different oftentimes for many of the rural hospitals from what they're used to, because even if they have a surgeon on site, for example, they can kind of spread that volume out over the whole month or over a whole week. Whereas we're going to concentrate all of that effort into single days at a time. So we oftentimes need to kind of start small so that we can partner with the hospitals. We have resources on our side that come from some of our multi-specialty programs on the clinic side and on the OR side. So we'll come in and partner with them to drive the efficiencies necessary to get those days to be pretty busy. And then we just start to add days with those specialists over time until we hit kind of that maturation point where our goal is really to kind of get 70 to 80% of that local market staying at the hospital. There's still always going to be cases that don't make sense to be done in a critical access hospital, and we're acutely aware of that and want to preserve that. And so we want to be on the fairly conservative side and make sure that we're capturing what makes sense to be done in that hospital, but maybe not everything.
Sure.
And then we'll go from there. So we typically will start with one specialty, although there are cases where we've started with multiple. But again, because of this kind of shift in mentality, we like to start with one, and then we start to address other specialties as things get going to continue to kind of support those hospitals over time.
And I assume that's probably where the expansion comes into things like you mentioned earlier, urology, GYN, general surgery, et cetera. Or would you guys possibly start with one of those as well?
Good question. So yeah, we would potentially start with one of those, but I would say usually when we're doing that, it's because the hospital's already got an orthopedist that they're covering most of the cases with. Orthopedics is one of those ones that's a higher percentage of the cases are elective in nature, so it's a little bit easier to be there less frequently. And also, the orthopedists are really good practice builders and can kind of come in and build practices quickly. So that typically is the right place to start. And it can kind of help fund some of the other specialties as we get going too. So we oftentimes encourage that approach. Obviously, we were founded by an orthopedist, so we're probably a little bit slanted to that process, but we really think that can help fund a lot of the other specialties as you get rolling.
Yeah, I could see that being a good baseline of success, meaning you guys can make that work and then really make the case for how this could work in other areas as well.
No, I think that's exactly right. It's a good benchmark. Obviously, it's a lot of what we still do to this day, but it just proves the model out, to your point, and allows for the hospital and the community to understand that this does work and that we can bring other specialists in and make it work on that same basis.
Chris, the nature of your program, Partners is in your name. That's significantly different than for example, having a locums come in and provide some surgeries on a temporary basis. Can you talk a little bit about, just at a high level, what those differences actually are?
Yeah, no, that's a really good distinction. And I hate to say that we're a little sensitive to being thrown in the same bucket as locums, because I know locums is a really valuable component of medicine out there, but we do get kind of lumped in with that. And I think we view ourselves very differently than that. We think of ourselves as a partner in building sustainable surgical programs. So our job doesn't end with the recruitment and then the staffing of the physician. We are there to build sustainable programs. And so that partnership looks different than locums in a couple of different ways. One of which is that the physicians are coming on a recurring, consistent basis, and it's the same surgeon for the same service indefinitely. So this isn't a coverage model. This is about, again, building these programs up and supporting them long term. So that physician will be there on the same schedule, all the time. So you're kind of partnering with that physician to help build your practice up. Whereas, locums is really more kind of filling the hole in the leaky bucket type approach. So yeah, it's a great distinction, great question. But yeah, our partnership continues. And, we've got some examples over time where, we start with just 2 days of orthopedics, and then we get up to 6 or 8 days of orthopedics, and then we're bringing in hand surgery and urology and spine and pain management. So that does not happen all at once, and we oftentimes don't support the programs in trying to do it all at once. So it's very much a long-term program where we're kind of constantly evaluating the market, what capabilities the hospital has, what they'd like to add, what the gaps are from a community perception, and then we build around that.
Chris, a quick follow-up question on that. If I've got the same physicians coming to the same hospitals, presumably I'm working with the same staff, or at least a limited variation in that hospital staff. Your team is bringing in some treatments and some subspecialists that they might not otherwise have. have you heard, and maybe this is an opportunity to toot your horn a little bit here, but have you heard of kind of a halo effect of the maybe additional training or just by the nature of those nurses and other staff working with those doctors, where that's impacted care across the hospital, maybe even outside of the patients that are being handled by your physicians?
Yeah, so I'm gonna answer that question in kind of two parts. One, I think that when, as we discussed earlier, when we get in and oftentimes the surgical suite is underutilized, that staff is obviously getting less frequent reps in the OR and in the clinic, which it's hard for anyone to become hyper competent when you just don't get those reps. So one thing that definitely happens is that staff could, after a year working with us, could go work kind of in any market for that matter, because we've just educated them on kind of a private practice model. And oftentimes we send them to other hospitals to get cross-trained. So go see one of our programs that runs super efficiently. We also support staff sometimes by bringing in, like, for example, a surgical tech that works for us on a contract basis. We'll bring in to help support and train that staff. And so, yeah, we support the staff in kind of expansion of their capabilities over time. So I definitely think that leaves the hospital in a better position. And then your second question about Halo is a really important one, because, I think that there's a perception about critical access hospitals, even in the communities that they serve, that they're oftentimes a emergency room with some primary care attached to them. So, which looks and feels very differently than a medical center in the middle of an urban area. So, I think as we start to bring in specialty services into these hospitals, the community starts to view them more as a medical center, and then they're seeking them out for all types of care. So what happens is that it is a halo effect where it started by surgery, but it's extended by the fact that the reputation of the hospital is just being elevated in the stature of the community. And so we see some really big financial impacts that reach far beyond just the surgery side of things. And so, yeah, I think there's a huge kind of halo effect from just bringing incremental specialty services to the hospital.
Yeah, that distinction, I think, is very important, and probably, again, one of those things that may be even underestimated, because that is the perception that many smaller rural communities have on their town's small, let's just say, critical access hospital. You described it very well, actually. That's definitely a trend I've seen. But when you do start building up higher quality specialized services, that really can change the dynamic of that facility, as well as the services kind of reaching out to the community, particularly when you're talking about not just ortho, but you can have your GYN services here, your urologist can be here, whatever it may be that you guys cover. That's a big thing. And then the distinction too, I thought, Richard, I'm glad you asked about kind of that, even though it's not really a comparison, as Chris, you said, but that you guys getting lumped in with kind of the locums model, because this is more like, as you were describing it, Chris, you're building and running an entire service line for this facility. And that's a service line that they, for whatever reason, were not able to or willing to develop on their own. And so that's a huge resource for them and that community.
Yeah, no, I mean, I think that's absolutely right. We've seen it in a number of hospitals. It does take some time to develop. I would love to say that, like, the day we're doing surgery, that halo effect pulls through. But we've seen a number of our kind of long-standing partners where we have started with a couple of days of orthopedics into multi-specialty, build new hospitals or expand hospitals. And that's, again, not all from the surgical support. That's coming from this halo effect for sure. So we've absolutely seen it play out in a number of some of our oldest programs.
Yeah. two quick things I'd love to get you to chime in on that you guys have seen and have dealt with. One is, I'm just curious, with COVID the last now, year and a half or more, how has that affected RPM and what you guys are doing with your partners, if any? Because I could see that honestly playing a role in you guys' growth in terms of how you guys can fit in to keep some of these services home, to not have patients have to go to A, travel, and B, be in a much larger urban or metropolitan based hospital environment. Has that affected you guys at all?
Yeah, so obviously we're elective surgery mostly. So there were times like in early days of COVID where there were some health directives put in place that limited surgery in certain hospitals. So we saw actually like a negative impact to the company, although that was very short-lived. So most of that kind of reversed right away as those health directives got loosened up. So from a company perspective, it really was kind of negligible, the impact of COVID. Obviously, there was a lot of uncertainty and things we had to address on how to keep the physicians safe and operationalize the things relative to COVID, which was, honestly, on a relative scale, very small for us compared to the hospitals that we partner with. They obviously had, kind of a massive amount of focus and energy around COVID and how to treat those patients and how to manage those patients. Now that the hospital systems are in a place where they know kind of the routine of how to manage COVID patients, I think the focus is now starting to transition into, okay, I need to figure out how to grow the revenues of my hospital, which is something that just culturally while we think we've got a great solution, it's still a cultural thing. Many of the critical access hospital, both boards and administrators, focus a lot on cost containment and have less focus on revenue generation and those types of things that may have a little bit higher risk profile to them. Although I would tell you that our model is almost riskless, but it's just perception. But I do think that now we're in this post kind of COVID or at least in this COVID environment where we kind of know how to manage patient care, that the focus is starting to really loosen up around where can I drive new revenue sources, which I think will lead very quickly to RPM and specialty medicine more broadly. So we're seeing a pretty big influx of people interested in what we're doing. And obviously excited to help as many hospitals as we can, because we really do truly believe that we can help bolster these hospitals up.
Yeah, that's actually a good segue into the second question I had. With the onset of COVID and the impact it's had, particularly to your point in the earlier stages, there's still some today. The just hyper growth of an acceptance of telehealth was something that we saw everywhere across the board. But what I thought was interesting was prior to long before COVID, telehealth was around and it was growing probably more so in what I would say is the rural space, the rural markets, specifically for access and some of the challenges there. And so I'm just curious, how's the overall concept of telehealth played in with your partners and the services that you guys are providing? Obviously not on the procedure side, but I'm just thinking in terms of follow up and some of the stuff that can be done electronically, digitally, and remotely. And then obviously, keeping the services themselves local. Is that played?
It surprisingly didn't have a significant impact on us. We did some telehealth through some of the moratoriums that were placed in early COVID days, just to make sure that we were continuing to see follow-ups and potentially a few new patients. So we did handle a little bit of that. I do think it's a huge opportunity, both for us in our current service offering, but also in the expansion of service offerings to the hospitals, because there's a number of specialties that really that should remain clinic only focused out in these communities that could be done tele, and it would be much more of an efficient model for the physician and for the hospitals themselves. So that's certainly something that we've evaluated over the last 12 to 18 months, and something that you'll probably see us do in some fashion. I do think that we could further enhance our existing surgical program by offering some telehealth support. But I don't find it to be something that's going to displace a lot of what we're doing today. As you think about orthopedics, it's just such a physical medicine that it's hard to really drive a lot of things through tele. But follow-ups and those types of things could absolutely be done virtually, which would maximize the time of the surgeon for the hospital and for the physician when they're actually on site. So there are things like that we're definitely evaluating, and some things that you'll probably see come out from us in the next 12 months that kind of expand our reach and support of the hospitals.
That's great.
Well, Chris, do you have kind of a unique success story, clinically maybe?
So on the success story side, we've got a number of them which we're very proud of. I'll share a little bit of one which I've kind of hit on through some of this discussion. But one of our hospital partners, when we got involved with them, was about a $20 million net revenue hospital at the time. And then kind of over the first 10 years of our partnership there, we started just like we talked about. It was actually Dr. Shear who started there and provided basically 2 days a month of orthopedics. And then we've grown that program up over time to include 4 to 6 days a month of orthopedics. We've got 2 days of foot and ankle. We've got 2 days of hand specialization. We've got 4 days of urology. We bring spine out with pain management a couple times a month. So we've grown it into a multi-specialty practice. And the hospital over those 10 years has kind of doubled in net revenue. So pretty significant amount of progress that has been made at that hospital. Surgery and ancillaries, so attached to surgery represents about a third of that revenue. So we were certainly a big component of the progress there, but really exemplifies also the halo effect in the financial performance there. It's just been a great partnership. It's one of the things that's made it a great partnership is kind of this two-way street that we have with them. Like all partnerships, it can't all come from one side of the partner, and they've just been a really good partner and have really heeded a lot of our advice, but also done some things independent of us based on some advice of ours. And so it's just been a really great partnership, and we're really proud of it. They've built several new wings to the hospital. Most recently, they put labor delivery floor in, and it's as gorgeous as anything as you would see in an urban market. So, just seeing some of the effects of that, and just a very well-run hospital with really happy staff and just a wonderful kind of pillar in the community.
Yeah, that's a great story. And I mean, as you're talking about this, it's one of those things that I could see would be compelling to many critical access hospitals and rural health facilities out there. I mean, there's a tremendous potential opportunity. It probably isn't something that works for every single one, and like you said, these things are going to take time to really matriculate and grow and kind of reap the full value, if you will. But opportunities like this, I think, have not been out there for a lot of these facilities, and so and the communities they serve. So I think this is something that is really compelling, and for our listeners, this is something we wanted to highlight. We don't have any financial relationship with RPM. Coker and RPM were friends, and kind of operate in similar markets, but this is purely about educating our audience on the potential opportunities that are out there for something like this, whether you're a provider or you're on the facility side, or anything else in between. So, Chris, I really appreciate you coming on. We're excited to know you guys and to continue watching how you guys are growing and expanding here in the future.
Yeah, appreciate that, Mark and Richard. Great to talk to you this morning, and appreciate the support of RPM, and look forward to working with you guys.
Absolutely. Thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.